Very much, Professor Werner. Nobody has to introduce Professor Werner, head and chairman of the Department of Otolaryngology, head and neck surgery in Marburg. And the last slide, I remember very well. I have it in my department, because in 1998, when you have been deputy chief of the department in Kiel, you had the first meeting on metastasis in head and neck, and so you continue with your really very successful work. The next gentleman is Professor Wendt, also very famous. He's the head of the Department for Radio Oncology in Jena, and Professor Heinrich Ihro, head and chairman of the Department of Otolaryngology, head and neck surgery in Erlangen. Now, you gave really a very comprehensive lecture, and there are some questions. One is there a site or a tumor in head and neck when we should not perform a neck dissection? Maybe from your point of view as a radiotherapist?
Yes. In the early laryngeal cancer, we probably should avoid neck dissection, and in these cancers, laryngeal cancer confined to the vocal cord, we would either treat by surgery, laser surgery, or by radiotherapy. And even by radiotherapy, in these patients, we would not include the nodes. Of course, there are very few patients who probably have nodes, but you can rule out them by ultrasound.
Uh-huh. So you are a specialist in ultrasound, Professor Ihro. Is this the tool we have to define N0 neck ultrasound, or?
I think ultrasound is a very useful tool, especially in the European countries, in Germany, Switzerland, and so on. And I think it's very useful to find lymph nodes. But it's sometimes very difficult to differentiate between benign and malignant lesions. And we have some signs. That means if the lymph node has an oval shape, it's normally benign. If the lymph node is round, then it's very often malignant. If you find inside the lymph node a vessel, that means a hilum of a vessel, normally you have a benign lymph node. If the hilum is missing, very often it's malignant. But it's not possible to say this lymph node is really malignant and this lymph node is really benign. You have a sensitivity and specificity using ultrasound from about 80 to 85%. It's very high, but it's not the truth. And therefore, in our hands, it's very helpful for diagnosing before treatment, during and after treatment. But you must know that it's not true in all cases. It's helpful to use, and I think ENT surgeons should use ultrasound by themselves.
Now, in all the sessions we had before, our American friends, I think, are not so very familiar with ultrasound in the hand of medical oncologists, radio oncologists, or whatever. They trust on maybe PET scan or so. Can you comment on that? Who likes to?
I think Rainer Ihro's more experience.
I think in Erlangen we made an investigation. We compared ultrasound in the neck with CT and MRI scan in the neck. And dealing with neck nodes in primary of the head and neck regions, we have found the same sensitivity and specificity dealing with lymph nodes using ultrasound compared to CT or MRI. But you must mention that using CT or MRI, you are able to look at the primary. That's the advantage of CT or MRI scan. But in our hands, the diagnostic measure of the first choice, looking at the neck, is ultrasound.
So,
I think there's one aspect extremely important, that of course you need somebody very experienced in this technique. So we have two co-workers in my department. They are doing this, I think, in a very good way. And of course the residents have to learn this, but I think if you have somebody extremely experienced in MRI scan, he will detect the smallest lymph nodes, and it may be the same for the ultrasound. But I think it's very helpful for the surgeon if he is able to do the ultrasound, not on this very high level probably, but for orientation before the surgery. So I think this is another aspect, because you are able to use this dynamic examination procedure.
Professor Wen?
For patients considered unresectable, we perform also radiotherapy planning, the NMR, routinely to detect lymph nodes, and this allows us to detect also lymph nodes in the retropharyngeal space, which is very difficult to access by ultrasound. And probably in the future, when we have the OSPIO as a contrast material for the NMR, probably this will change the results in the neck.
Okay, so I learned from your lecture that a sentinel node is not the key to solve the problem. Is one of the panel different opinion? Sentinel node to find out if there should be done a definite neck dissection?
I think we can learn a lot of this procedure, sentinel node biopsy. But we have a completely different situation compared to the breast cancer, because we have more than 300 lymph nodes in the head and neck area. We have a very close relationship between the tumor and the first draining lymph nodes. So it may be helpful to detect the sentinel nodes. Mostly, for example, in oropharyngeal cancer, we have at least 2 sentinel nodes. And probably we can decide in a more proven way the next therapeutical steps. But it is definitely not okay to use the sentinel node biopsy today as the only treatment for head and neck cancer. And there are some institutions, they are doing this. There is a T2 floor of the mouth cancer. They remove 1 or 2 lymph nodes, and then they see there is no lymph node metastasis. And I think it is too risky to do this by yourself, not proven in prospective studies or so. But I think this is a risk, a high risk.
Professor Wen? You like to comment?
Yes, for us it's another aspect, but the same problem. We very often have an increasing number of patients who come from the surgeon with, let us say, 40, 50 nodes removed. And in these 40 or 50 nodes, there are, for example, 2 or 3 positive nodes. What to do? What to treat adjuvantly? And I think this is an open field to debate.
So now we had a lot of discussion in the other sessions if we should start with an induction chemotherapy or concomitant radiotherapy, and if we should do a laser surgery. And Pat Bradley asked if T and N is completely different. If we do a neck, do we use it as a diagnostic tool to stage the case, or do we start with introduction chemotherapy or concomitant radiotherapy, and later on we do the neck? You like to begin?
I think the question for the neck dissection is first, how will we treat the tumor? If we decide to treat the tumor surgically, then the next step for the neck will be a surgical procedure in the neck. So it's an N0 case. We have to decide, is it a diagnostic procedure or a therapeutical one? If then after the selective neck dissection there is only one lymph node metastasis, we can discuss, shall we stop or shall we go on with the radiotherapy? Probably the tumor is completely removed, T1 oropharyngeal cancer, one lymph node metastasis level 2A, no extracapsular spread, selective neck dissection 1, 2, and 3. So I think we can have the discussion not to go on with the radiotherapy. There are a few papers, they show that it seems to be possible to do this in a safe way, but I think this is a difficult aspect. It's very complicated. Yeah.
Maybe our radio-oncologist can comment on that, because for you, if you irradiate a patient, maybe it is a big chance to know in which level you have to enhance the doses or reduce the doses, because it is a negative level, isn't it?
Yes. First, I find it somewhat risky to neglect to do not radiotherapy in such a case. Let us say a T2 tumor with one positive lymph node. I think there are no data supporting such a procedure. Probably it depends on the number of lymph nodes which have been removed. Let us say if the patient comes with 50 lymph nodes removed and one is positive, we can debate about that. I would probably agree not just to do follow-up. But if the patient comes with 5 nodes resected and one was positive, I would not agree not to do radiotherapy postoperatively.
But if we would have a selective neck dissection, we do not have 5 nodes. Something is wrong. The pathologist did not investigate the removed lymph nodes, or it was an incomplete surgery. So there will be a higher number of lymph nodes. And I started this discussion with the T1 oropharyngeal cancer. But of course we can go on with T2. But I think everybody has his way. If you visit some other centers, they tell you, oh, in cases of T1, N1, we do no radiotherapy. It's okay, but there is not an agreement about this. I think this is our problem. So you can travel all over the world, and every place has a special therapeutical concept. This is for me very strange.
So is there any evidence for what we are doing?
Yeah, I think, of course, there are some papers reporting on also higher numbers with these small tumors and the high located lymph node metastasis, no extracapsular spread, showing that there is no difference in the outcome with or without radiotherapy. But this was a good example. I started with the example, and the radio-oncologist said, oh no, in this case it would be too riskful. So we have this discussion in all tumor boards. And then the radio-oncologist, they can bring the argumentation, okay, there is no multi-center prospective trial on this debate, so we have to be on the safe side, and in the future, until there is no trial, we will go on with radiotherapy. This is, in my opinion, a problem.
You like to comment on that, Bhuvanesh or Chetin? Can you give him the microphone?
Carl, it's interesting you say that, is there any evidence? Yes, there is evidence, and there is level 1 evidence, but human memory is very forgetful. We only remember what was published in last 2 years and not what was published in the past. The very first randomized trial of adjuvant radiation therapy in conjunction with neck dissection took place at Memorial Hospital in New York from 1959 to 1968, consecutive series of patients with N plus neck who got preoperative radiation followed by neck dissection. And these were randomized patients. That trial, and the paper is published in Surgical Clinics of North America, April 1969. If you want, I can give you the page number. That study showed that without radiation therapy, the recurrence rate in the neck with multiple positive nodes